everyone, I am Shalini Monti, nursing tutor of Index Medical College. Today I discuss about wound healing. Introduction. A wound is a dissection of the normal structure and the function of the skin and underlying tissue. Acute wound in normal, healthy individual heal through an orderly sequence of physiological events that include hemostasis, inflammation, epithelialization, fibroplasia, and maturation. When this process is altered, a chronic wound may develop and is more likely to occur in patients with underlying disorder such as peripheral artery disease, diabetes, venous insufficiency, nutritional deficiency, and other disease states. Wound mechanism. Wounds are generally classified as acute or chronic. Chronic wounds are generally associated with physiological impairment that slow or prevent wound healing. Wound may be caused by a variety of mechanisms, including acute injury to the skin, abscession, puncture, crush, surgery, and other etiologies that cause initially intact skin breakdown, ischemia, pressure. Surgical wound. Surgical wounds are a controlled form of trauma created in the operating room environment, classified according to the degree of bacterial load or contamination of surgical wound. The categories clean, contaminated, and dirty are used to predict the risk of surgical wound infection, which can impact wound healing. The majority of clean and contaminated wounds are closed primarily at the completion of surgery. Contaminated and dirty wounds. Example: fetal contamination, debridement for wound infection are typically packed up. Phases of wound healing. Wound healing occurs as a cellular response of tissue injury and involves activation of keratinocytes, fibroblasts, endothelial cell, macrophages, and platelets. The process involves organized cell migration and recruitment of endothelial cell, agenesis, mini growth factor, and cytokines released by this cell type coordinate and maintain wound healing. Then, acute wound transition throughout the stage of wound healing as a linear pathway with clear start and endpoints. Chronic wounds are arrested in one of these stages, usually the inflammatory stage, and cannot progress further. Hemostasis. Immediately after injury to the skin, small vessels within the wound constrict to provide at least a measure of hemostasis for 5 to 10 minutes. Platelets aggregate in separate vessels and trigger the clotting cascade and release initial growth factor and cytokines that are important for the initiation and progression of wound healing. Example: platelet derived growth factor, transforming growth factor beta. The fibrin matrix that result stabilize the wound and provide a provisional scaffold for the wound healing process. See, this is a hemostasis, red blood cell, fibroblast, big tissue, monocytes, platelet, blood vessels, and these are two layers hemostasis, epidermis and dermis. Hemostasis phase at the time of injury and fiber growth from the provisional wound matrix and platelet release multiple growth factors that initiate the repair process from granified editor surgery, scientific principle and practice. Inflammation. The leg phase because wound strength does not begin to return immediately. The inflammatory phase is completed within 3 days, except in the presence of infection or other causes of wound chronicity. The components of this phase are increased vascular permeability and cellular recruitment. The presence of necrotic tissue, foreign material, and bacterial result in the abdominal production of metalloprosthesis, which alter the balance of inflammation and impair the function of cytokines. Inflammation. The leg phase because wound strength does not begin to return immediately. The inflammatory phase is completed within 3 days, except in the presence of infection or other causes of wound chronicity. The components of this phase are increased vascular permeability and cellular recruitment. The presence of necrotic tissue, foreign material, and bacterial result in the abdominal production of metalloprosthesis, which alter the balance of inflammation and impair the function of cytokines. The healing process of chronic wound usually become arrested in the inflammatory stage. Tissue injury cause inflammation and granulation and neogenesis, reepithelialization and tissue remodeling. Epithelialization, also called migration, refer to basal cell proliferation and epithelial migration occurring in the fibrin breachwork inside a float. It continues until individual cells are surrounded by cells of similar type. In a clean surgical wound, the epithelial cells migrate downward to meet deep in the dermis. Migration occurs when the layer is rejuvenated. This is normally completed within 48 hours of surgery. Though superficial layer of epithelium creates a barrier to bacteria and other foreign bodies. However, it is very thin, easily traumatized, and give little tensile strength. Epithelialization. Look, this epithelialization. Epithelialization. Dacellate. Epithelialization. Basal epithelialization cell migrate into wound area. Contact with basement membrane broken. Fibroplasia. Fibroplasia contained with fibroblast, proliferation, accumulation of ground substance, and collagen production. Fibroblasts are transformed from local mesenchymal cells are usually present in the wound within 24 hours and predominate by the 10th postoperative day. They attach to the fibrin matrix of the clot, multiply and produce glycoprotein and mucopolysaccharides which make up ground substance. Fibroplasia. Fibroplasia produce contractile protein. This contractile cell, which are lysine myofibroblasts, are present in the wound by the fifth day and have characterized of smooth muscle cell with the ability to contract. Myofibroblastic cells are lost via apoptosis as repair resolved to from scar. In pathological fibrosis, myofibroblasts persist and are responsible for fibrosis via increased matrix synthesis and for contraction. The exacerbate scarring may impede normal organ function or in the case of skin result in keloid. Fibroplasia. Fibroblasts are also synthesize collagen, the primary structure protein of the body. Collagen production begins on the second postoperative day when it is scarred and amorphous gel devoid of strength. Maximum collagen production does not begin until day 5th and continues for at least 6 weeks. The developing collagen matrix stimulates angiogenesis. Granulation tissue is the result of the combined production of collagen and growth of capillaries. Maturation. Key elements of maturation include collagen, cross-linking collagen, remodeling and wound contraction. 5 types of collagen have been identified. Types 1st and 3rd predominate in the skin and aponeurotic layer. tensile strength of the wound is directly proportional to the amount of collagen. As disorganized collagen is degraded and reformed, covalent cross links are formed format that enhance tensile strength. Maturations. This type are fibroblast and second fixed tissue monocytes, then third blood vessel and macrophages. Remodeling phase has resist the initial disorganized scar tissue is slowly replaced by a matrix that more closely resembles the organized extracellular matrix of normal skin from Greenfield editor surgery scientific principle and practice. Maturations. Maximum strength depend upon the interconnection of collagen subunits. Approximately 80% of the original strength of the tissue is obtained by 6 weeks after surgery, but the diameter and morphology of collagen fibers do not have the appearance of normal skin until 180 days. Rest and mobility are important during the immediate postoperative period for successful healing to occur. However, some physical activity is essential during the maturation phase because light tension increase tensile strength by remodeling, which may continue for many years. Injury, platelet release, growth factor, and cytokines, then decrease neutrophils and macrophages. Engulf bacteria, release growth factor, cytokines and process, then decrease epithelial cell, fibroblast and endothelial cells. Product growth factor, then decrease synthesis of ECM and new capillaries, fibroblast orchestrate and the remodeling of the scar by producing ECM, MMP and then decrease mature scar. The three first inflammatory phase, second prophylization and repair phase, then remodeling phase. For decreasing macrophages and neutrophils attracted into the wound, then fibroblastic epithelial cell and endothelial cell attracted into the wound. See the structure of the phases of continuous wound healing. First stage and then 48-hour stage and prophylization 72 hours. First early examination, remodeling weeks, months. Tensile strength. Tensile strength. The tensile strength of wound is measurement of this load capacity per unit area. The bursting strength of a wound is the force requirement to break a wound regardless of its dimension. It varies with skin thickness. Then third, peak tensile strength of a wound occurs approximately 60 days after injury. And fourth, a healed wound only reaches approximately 80% of the tensile strength of unwounded skin. Impaired wound healing. There is usually not a single primary factor that contributes to impaired wound healing. There are multiple smaller contributing issues that can disrupt the process. As examples, local tissue ischemia and neuropathy can impair chemotaxis during the hemostasis and inflammatory stages. Tissue necrosis and infections alter the balance of inflammation and compete for oxygen. Uncontrolled prevent edema and wound instability, disrupt myofibroblast activity and collagen deposition and cross-linking. Risk factor for non-healing. Chronic wounds affect a substantial proportion of the population and contribute to a significant burden in the hospital settings. Certain patients at risk for development of a non-healing wound such as first, impaired arterial or venous circulation, and second, immunocompromised stage. Then third, the elderly, and fourth, diabetics, and fifth, any patient with neuropathy or spinal cord injury. And the most common non-healing wound affected the lower extremities are associated with peripheral arteriosis, diabetes, and chronic venous insufficiency. Peripheral arteriosis. Several peripheral arteriosis (PAD) with multi-level arterial obstruction decrease arterial blood flow, damages the delivery of oxygen, nutrients to the tissue, and impair removal of metabolic waste products. Critical limb ischemia develop when blood flow does not meet the metabolic demand of tissue at rest and manifests clinically with extremity pain and non-healing wound or tissue loss. Diabetes mellitus, it's a DM. Diabetes is a particularly important risk factor for the development of chronic wound because it is associated with vasculopathy, neuropathy, and immunopathy. It is frequently associated with severe PAD with altered sclerosis develop, developing at a younger age and affecting more distal arteries. PAD in combination with diabetic neuropathy contributes to higher rate of non-healing ulcer and limb loss in diabetic patients compared with non-diabetic patients. Then approximately 50% of patients with diabetes in the United States will develop a foot ulcer. Peripheral artery obstruction is present in about 20% of this patient and diabetic neuropathy in about 50% with about 30% having both. Diabetic mellitus. Neuropathy alone can be responsible for the development of diabetic foot ulcer. Neuropathy associated with diabetes affected sensory motor and autonomic nerves. Sensory neuropathy diminishes the perception of pain that is protective when tissue injury has occurred. The motor nerves to the intrinsic muscles of the foot are affected in approximately 50% of patients with diabetic result in claw deformities that transfer pressure to the plantar metatarsal heads. The autonomic neuropathy causes the skin to become dry and susceptible to skin fissure, tearing, and infection due to a loss of sweat and oil gland function. Over 100 known cytologic factors contribute to impair wound healing in patients with diabetes. This include decreased or impaired first growth factor production, second angiogenesis response, third macrophages function, and collagen accumulation, then epithermal barrier function, quality of granulation tissue, etc. Then aging. Skin is not included from the complex process of aging. The supply of continuous nerves and blood vessels decrease with age and a general thickening of tissue, including dermis and basement membrane. There is a loss of collagen and ability to produce more collagen. This psychological changes associated with aging contribute to slowed or impaired wound healing in the elderly. Sickle cell disease represents another from the local tissue enzyme at the specific location of the wound. It is also obstructive in nature, similar to chronic peripheral artery disease, but is caused by dysmorphic RBCs physically occluding small vessels, usually of lower extremities. The location and appearances of sickle cell wound may be similar to ischemic and venous ulceration. Sickle cell wounds are known to progress much slower throughout wound healing and carry increased risks to reoccurrence. Chemotherapy. The administration of chemotherapy may have a detrimental effect on wound healing, especially through its effects on vascular endothelial growth factor VEGF. It's a vascular endothelial growth factor is an important factor contributing to angiogenesis during the earlier stage of wound healing, but may also be an important regulator in malignancy and thus is a target of cancer therapy. Similar to this effect, any patient on immunosuppressive therapy is at an increased risk for the development of chronic wound and wound infection. Radiation therapy. Radiation therapy has evolved as a powerful tool for tumor control as a sole therapy or administered preoperatively. Then second, more than 50% of cancer patients receive some from the radiation treatment, and despite improvements in radiation technique, radiation include injuries still contribute to poor wound healing. Then third, the terms radiation injury refer to morphologic and functional changes that can occur in non-cancerous tissue as a direct result of ionizing radiation and may include apoptosis with low doses of radiation or outright tissue necrosis with higher dose of radiation. Radiation therapy. Radiated skin in the chronic stage is thin, hypovascular extremity, painful, and easily injured by slight trauma or infection. Skin ulcer due to radiation injury are more commonly delayed in presentation and are due to enzymatic tissue change. Characterized features of delayed radiation injury include an enteric myotomal proliferation in the small artery and arterioles. This ulcer heals very slowly and many persist for several years. Spinal cord disease and embolization. Patient undergoing period of prolonged immobilization, particularly those with spinal cord disease, are at an increased risk for the development of chronic wound. These are typically pressure wound, similar in pathogenesis and appearance to neuropathic wound occurring in area of bony prominences which the sacrum, knees, ankle, malloy and heels. Malnutrition. Nutrition is an important component of wound healing. Several studies have indicated the nutrient deficiency are more prevalent and cause delayed healing in patients with wounds. The extent role for nutrition and nutritional supplementation in the management of wound and remain uncovered. Malnutrition. Malnutrition. Vitamin C is a call factor for collagen cross-linking. Lack of available vitamin C or scurvy impacts the hydrolyzation and consequently the collagen fails to aggregate into fibers. Vitamin A, potentious epithelial repair and collagen synthesis by inhibiting inflammatory reaction, particularly macrophages ability. Minerals also may affect healing. Zinc deficiency reduce the rate of epithelialization and retards cellular proliferation and collagen synthesis. Infection. The presence of infection impairs several steps of the wound healing process. Bacteria produce inflammatory mediators that inhibit the inflammatory phase of wound healing and prevent epithelialization. Recent development that can appetite healing of wounds. Negative pressure wound therapy, also called vacuum assisted wound closure, refer to wound dressing system that continuously or intermittently apply subatmospheric pressure to the surface of a wound. And PWT has dramatically changed the surgical approach and time to heal a wide variety of complex and difficult wounds. जैसे कि आप देख रहे हैं यहाँ पे प्रेशर वुंड है उसको प्रेशर की तरह क्लोज करके रखा है. Negative pressure wound therapy (NPWT) exerts its effect through directly and indirectly effect of subatmospheric pressure. This effect include stabilization of wound environment, increased blood flow and deformation of the wound. inflammation is a powerful stimulus and negative pressure wound therapy. Advantage provides a close to ideal environment for temporizing coverage, provides a most environment and promotes and accelerates the growth of healthy granulation tissue while decreasing the presence of infections agent. Use effectively in a variety of wounds can be used as a long-term dressing. Its use has increased the need for secondary amputations, remove excess fluid, and promote wound contraction. Technique of VAC fluid evacuation. VAC vacuum assisted wound closure. The foam insert sponge within the wound and covered by a clear vapor permeable plastic dressing. Continuously sub-atmospheric pressure suction applied throughout the tube causes fluid to flow out of the wound. Contraindication exposed vital structure. Ongoing infection. Third, devitalized tissue. Fourth, malignant tissue. Fifth, fragile skin. Adhesive allergy. Ischemic wound. Expedited wound healing and non-contact low frequency ultrasound therapy in chronic wound. A retrospective analysis study overview. This was a retrospective observational study that arrested the clinical role of mist therapy in the treatment of chronic lower extremity wound including venous leg ulcers, ischemic lower extremity ulcers, neuropathic lower extremities ulcer, and multifactorial ulcer. In included 210 patients, 163 those treatment included mist therapy plus standard of care and 47 who received only standard of care, accelerating the rate of healing. Mist therapy uses low frequency ultrasound to stimulate cell at the below to wound surface to active healing, a painless procedure. The system creates low frequency ultrasound waves that produce and propel a gentle mist of sterile saline into the wound bed. The saline mist improves the transfer of ultrasound from the device without contact, or pain to the patient. Mist therapy promotes painless wound healing thought first active cell stimulation, second decrease bioburden, third increase blood flow, fourth cleansing and gentle debridement. Mist therapy. In this equipment used in mist therapy, this is a saline bottle needed to deliver ultrasound waves to wound. Appliator, second appliator, this show to appliator single use. Transcriptor tip vibrate up 40,000 times per second to create the gentle ultrasound waves. Then third, transfiller delivers energy to the transfiller tip. Key findings. Wound reduction was achieved in 72 of patients using mist therapy, whereas 46% of wound treated using standard of care alone. Wound closure was achieved in 70% of all wounds treated with mist therapy as compared 20% of wounds treated with soap alone. 50% of wounds treated with twice weekly mist therapy healed over a mean of 147 days. Just 32 of wounds treated with soap alone healed with over a mean 134 days. Summary. A wound is a disruption of the normal structure and function of the epidermis. Wound may be caused by a variety of mechanisms including acute injury, surgery, or other factors. There is no specific time frame that distinguishes between acute or chronic wound. Chronic wounds are associated with physiologic rearrangement that impair the wound healing process. After summary, after hemostasis have been attached, acute wound normally heal in an orderly and effective manner characterized by four distinct but overlapping phases: inflammation, epithelialization, fibroplasia, and maturation. Many disease states alter the process of healing, wound healing, the most common of which are PAD, diabetes mellitus, and chronic venous disease. Vacuum assisted closure is an adjunctive therapy used in the management of open wound that applies subatmospheric pressure to the wound surface. Thank you.